So thank you so much to everyone who's joined. I think we will get started. There are people who are still entering the session. My name is Vahed Lokant, and I'm pleased to welcome you to today's webinar on trauma and the body, including somatic work in trauma treatment. For those of you who are long-standing attendees of our webinars, welcome back. For those of you who are new to EHN Canada, we are a leading nationwide network of treatment centres for addiction, trauma, and mental health. We offer inpatient services with centres coast to coast, as well as intensive outpatient and virtual treatment options. For more information, visit our website at ehncanada.com. Everyone is on mute and cameras are turned off for today's webinar, but feel free to use the Q&A box to submit your questions for our speaker. We will be leaving time at the end of the presentation, and we'll try our very best to get to everyone's questions at that time. We will be sending a follow-up email in the next week that will contain a link to the recording of today's session, as well as access to your attendance certificate that you can use to submit to your association for continuing education credits. To stay updated on future webinars and news, we invite you to opt in to our mailing list by filling out the form that will be linked in the Q&A box and the chat. Allow me to introduce today's speaker. Dr. Krystle Martin is a licensed clinical and forensic psychologist. She provides psychotherapeutic interventions and comprehensive psychological assessments for adult clients with a range of clinical and forensic issues, with a particular interest and expertise in working with first responders. This expertise brought her to EHN Canada, and in particular, our Gateway Recovery Centre in Peterborough, Ontario, as well as the Atlantic Centre for Trauma in Nova Scotia, two sites that are dedicated to treating first responders and active and retired military personnel. At these sites, Dr. Martin provides consultation to staff and supports program evaluation and research efforts. In addition to her work with EHN Canada, Dr. Martin is the director of a private practice and regularly provides consultation to various first responder organizations to advance their health and wellness initiatives. She is also an adjunct professor at Ontario Tech and York Universities, where she teaches and supervises graduate students. So now, without further ado, I will hand the stage over to Dr. Martin.
Super. Thank you so much, Vahed, and hello to everyone. I am very honored and happy to be here today. And while I live in Ontario, and that is where I mostly am supporting EHN through my work at Gateway. It is very exciting that this week I am in Nova Scotia, actually, and at the ACT site to support their efforts there. So again, as was introduced, my role really is to support clinical efforts, to provide consultation and guidance for the clinicians who are doing the work with our folks at these sites, and to bring some expertise on occupational stress injury, particularly when working with public safety personnel and military and veterans. So this brings us to our topic today, talking about how do we include and consider somatic work in the work that we're doing, particularly when providing trauma treatment. Focusing on the impact of trauma on the body is not new. There's some pretty prominent books and literature out there that have been talking about this for many decades. As far back as, in the 90s, Peter Levine in his book, Waking the Tiger, was talking about this. Van der Kolk's work on when the body keeps the score, right, was a few years after that. But so while these conversations have been happening for many years, there is less research on this approach in providing support and treatment for trauma. And so as a result, there is less evidence to lean on. And we know that evidence-based practice is really driving most of our healthcare, rightly so, as it should. But because of that sort of lack of evidence, and not to say that it doesn't work, but we don't see, primarily somatic approaches as much in healthcare right now that is looking at trauma treatment. But that's not to say that it isn't effective or that we shouldn't be doing that. And really, that is what brought us to this area in my work in supporting EHN, particularly at Gateway, which is what we're going to be talking about today. Is I'll go to the next slide around our agenda. And I know you saw this agenda before, but it's, again, looking at why did we start focusing on somatic work? So what is the rationale for including this in our trauma work? I'm going to talk a little bit about the impact of trauma on the body. So not so much necessarily on the brain, but what happens behaviorally and perhaps on an implicit level on our body, which again provides some rationale for why we would focus on somatic work in trauma treatment. And then I'll tell you a little bit about how we did apply this at Gateway. So provide an overview of the group that we created and how we embedded it into that inpatient programming, and as well as how we're going to be measuring the impact of including that intervention. And like was described, with so many folks here today, I do want to make sure that we save time for questions or comments. And so I have made sure that in the presentation, we will have that at the end. So again, why are we considering somatic therapy? So I've sort of introduced this a little bit, but at Gateway and certainly at other sites at EHN, the main therapeutic approach that guides a lot of the treatment is cognitive processing therapy, which certainly does have a lot of evidence to support the use and is quite effective. We've, through program evaluation and research efforts, we do see that those inpatient programs are leading to positive clinical outcomes and folks are getting better. But sometimes what we see, and I've seen this, whether it's at Gateway or in my own private practice, that sometimes clients are saying, yes, I am able to catch unhelpful thinking or those stuck points that really lead to distress, but I'm still experiencing physiological distress or having physical symptoms despite my ability to do those challenging and reframing of those thoughts, right? So there are sometimes residual symptoms that remain even when those thoughts are challenged, the stuck points are caught, and reframing or alternative thoughts are generated. This makes sense given what we know about trauma, right? So that there are ways in which trauma can have impacts on our body that are more implicit and that lie below our conscious thought, that are then therefore difficult to target when we're using an approach like cognitive processing therapy, which requires us to be able to identify those stuck thoughts. And really what I'm talking about here is that difference between approaches that are considered top-down approaches versus those that are bottom-up. So again, both of them are these ways of targeting trauma are meant to improve trauma symptoms, but they have a different approach. So something like cognitive processing therapy is a top-down approach, meaning that it really requires the knowledge and awareness through our executive functioning sort of system of thoughts that we have. And then it's understood that if we can challenge and reframe those thoughts, that then we have different emotional responses after, which then influences how our body feels, which then can influence our behavior. Whereas a bottom-up approach is really looking at how can we build awareness and intervene on our body, that physiological place first. And then if we can change that is what, is the mechanism of change, which then influences our emotional response, which then can impact our thoughts. And so in both ways, we are making sort of global changes, but it's the main target, which is different. So again, this is what we tried to do and why we started looking at somatic therapy is to identify perhaps other targets for treatment. So I mentioned that these bottom-up approaches or more global somatic therapies try to, again, target the physiological or the body's response to trauma rather than the more executive functioning and thoughts. And so rather than necessarily talk about trauma's impact on the brain or things like neurotransmitters, what I thought I would do is provide a little bit of education around three main areas that that can be impacted when someone undergoes or something like chronic trauma or even a more acute experience. The first one that can be adjusted based on trauma is something called neuroception. So neuroception is a neural process that occurs outside of our main perception. So for example, it's mostly searching for and identifying stimuli in our environment that is dangerous or safe, right? So it's our perception, again, sort of implicitly about whether our environment around us is safe or dangerous, or are there threats that we need to be aware of. So when we perceive that our environment is dangerous, the result of that can be that we feel a little bit less connected with our environment. Certainly that could be disconnection from the moment per se, but also socially if we are around other people. It can lead to a reduction in our ability to be flexible in our thinking, that it kind of narrows our thinking and focus in the environment, because it really is focusing on and directing our attention to whatever that danger or threat is. And our threshold for physiological arousal is lowered. And so one of the words in somatic approaches is talking about our window of tolerance. So it shrinks. So that means that we feel more impacted, perhaps we're more impatient or agitated, and we feel more uncomfortable with higher activation in our physiological system. So if we think about folks who've experienced trauma, they might then have the result of a less accurate neuroception ability in two different ways. One could be the overestimation of risk, right? So that they are perceiving things in their environment as more risky than perhaps they are. And this is about our system being sensitized because of being exposed to trauma. Or we might see the opposite, where folks are underestimating the risk in the environment. So they're less able, their neuroceptive system is less able to detect stress or threats in the environment. And this is really due not so much, it's not being sensitized, but it's actually due to, the need to suppress our response to threat in the environment. So we're more likely to see this in folks who perhaps had chronic exposure to trauma, perhaps through something like developmental trauma or trauma as one was a child, if they had a violent parent or something like that. But again, in the area that I work in, we also see this for folks who work in a public safety job or in the military, where they are chronically exposed to events that might otherwise cause a trauma response, but because of their role or occupation, they needed to suppress that natural response, right? So again, being able to perceive the danger in the environment might actually be less so because of that constant or chronic suppression. Another area where we see trauma having an impact on how our body responds to our environment is based on something called the orienting reflex or the orienting bias. So an orienting reflex is when we have it's a sort of our immediate response to changes in the environment. So right now I'm sitting in an office, and so if someone were to walk through the door, so they open the door, I might turn around and orient my attention to the door. It'd be hard not to, especially when I'm doing a presentation. And so for folks, in a normal or natural response, I would become oriented towards that stimuli in the environment. And my response would be more of interest, of curiosity. But when someone might have, may have gone through something like trauma, that orienting reflex might become a startle reflex. And then in that moment, our physiological response is much more activated, and our brain is perceiving that as threatening. And so as a result, our response is more defensive. And we see this just in the diagnostic criteria of PTSD is, someone has a heightened startle reflex. So again, they are perceiving changes in their environment as threatening, and so their brain is responding as if it's threatening, even when it's a neutral stimuli or something like someone opening the door. So again, if someone is having a startle reflex, this is a very narrowing of our attention. So the attention becomes extremely focused to whatever that stimuli is. And because our brain is thinking this might be threatening, then it's harder in the moment to experience things like pleasure or even connection, because again, our focus is redirected. And because our brain is thinking that it's threatening, our physiological response is around being prepared for having to be defensive or fighting back. We're, feeling like on alert. So that sense of like hypervigilance, and, we feel anxious in the moment. Now, over time, again, imagining someone with a trauma history engaging in the environment in such a way where their brain is having a startle reflex or a negative sort of orientation to changing stimuli in the environment, that over time, or over the course of even a one day, this is very tiring, right? So it's taxing on our system. They might feel fatigued. They might feel overwhelmed. Again, that window of tolerance shrinks, and so we become impatient, irritable, agitated. But because, like I was saying, this is about how our attention is oriented, we know that our memory system is impacted by attention, right? So we remember what we pay attention to. And so because our brain is kind of, on alert, it's looking for threats, it's sort of focusing and narrowed on those stimuli in the environment that are perceived as threatening, then our memory becomes skewed. So the person with a trauma history who is responding to the environment like this is going to be more likely to remember the stimuli in the environment that is kind of threatening or is negative, because they're not paying attention to the more neutral or benign stimuli in the environment. So when they think back on their day, when they think back on their week, what they're more easily able to recall are the events and experiences that are negative or threatening. The third way that I want to talk about in terms of the impact of trauma on our body is something called procedural learning. So this is a form of learning, again, that we all have, that isn't necessarily negative in and itself, but it's basically learning that happens on an unconscious level. So, a really sort of normal example of this is when you're learning how to ride a bike. So let's say now, even as an adult, if you never learned how to ride a bike, and I described it to you how to ride a bike in great detail, despite having all of that information and knowledge, when you hop onto the bike, it's not going to be easy, right? So it's still going to be difficult. Your body isn't doing it, even though you know, quote unquote, how to ride a bike. So there's something about through practice, being on the bike and practicing, that then your body learns something. And it's that procedural learning. And same with things like even like driving a car. Right now, my daughter is just about to get her license. And so we practiced a couple times. But there's something about, the awkwardness and clunkiness when you first get behind the wheel of a car, just like when you are trying to learn how to ride a bike. There's this flow that happens and natural ability that we develop over time that's hard to put into words. And so this is a body learning that happens. So again, if we think about trauma, that if someone goes through experiences or has things happen to them, or ways in which people have treated them that is negative, that is traumatic in nature, that this can also lead to some body learning. So one example might be a child who lives in a home with an abusive parent. So let's say they are home and the abusive parent comes home every day after school, and the sound of the door kind of closing indicates that the parent is home. The child now might have a more anxious response to that sound, that they aren't sort of consciously thinking about, and that then maybe they become a little bit more passive. Their posture might, close in on themselves. They might think, if I'm really quiet, then maybe I won't get, spoken to in a certain way. So again, their body becomes closed in, they get quiet, they get passive, and there's some body learning that gets paired with the sound of that door closing. Now, again, as that child grows up, that learning might not go away depending on their life experience. So let's say now they have a partner or a roommate who comes home, the door shuts, and that noise, or even time of day, will the body has learned to associate, oh, I better, be quiet. I better avert my gaze. I better shut down in order to protect myself. So again, it's not a conscious thought that the adult now has, but it's a learned body learning that happens to that. Again, in the line of work that I do, I could see a different example, let's say with a police officer who perhaps learns that in a confrontation at work with someone in the community, that if they adopt a bigger posture, a maybe more assertive or aggressive posture, that might help them in those interactions. And so that maybe then they bring that home, and in outside of work, that when there's a conflict, their body might learn that, oh, I need to get big, I need to get assertive or particularly aggressive in this situation in the face of that conflict. And yet in that circumstance or in that scenario, it isn't adaptive. And so again, it's really kind of these more adaptive body learning that happens or can happen in the face of trauma that in a different context becomes maladaptive and less helpful. So again, I can't go through all of the ways in which trauma impacts our body, but I wanted to highlight those because those are some of the things that, again, are less directly targeted in a top-down approach to trauma treatment. Something like cognitive processing therapy isn't focusing on necessarily those things, and so perhaps we are missing some of the impact of trauma. And this is maybe why we see some residual symptoms even when people complete a really effective treatment like CPT. So again, like I said earlier, I wanted to just touch on, something I said, where there really is not a ton of research on somatic approaches to trauma treatment. Certainly not as much as something like CPT or something like that. So, there are some research studies that have, for example, looked at a particular type of somatic therapy called somatic experiencing. In 2017, there's been some studies published that did look at somatic experiencing and the impact on PTSD or on folks with mental health symptoms and, let's say, something like back pain. In both of these studies, they did not have, the control group is really like a waitlist group rather than comparing it to other types of trauma treatment. In both of the research studies, the authors reported positive or a beneficial impact on trauma symptoms and other symptoms, and so improvements in those mental health symptoms. But like I said, they weren't necessarily comparing it to other trauma treatments. In 2021, there was actually a scoping review of somatic experiencing as a trauma treatment. One thing to note is there were no Canadian studies in that were identified through that review, and not all of the research studies included in the review were looking at folks with a diagnosis of PTSD. And so it was really heterogeneous across those studies. So again, what that does is just makes it hard to compare from one study to the next. But again, the authors were reporting that overall, most of the studies, when they were looking at impact on trauma symptoms with folks with PTSD, that these somatic experiencing interventions were demonstrating clinical improvements. And so again, this is positive. The research is growing, but we don't have a ton to rely on at this time. So as a result, what we wanted to do is to add to that literature, right? So we had a few different goals with our work at Gateway. So like I said, one of them was to contribute to the literature to start, or not to start, but to make sure we keep adding to that growing information that we have around somatic approaches. But also, like I said, in terms of the rationale, that while we were seeing really quite excellent response of clients who were completing our trauma treatment, that sometimes folks are identifying that they have residual symptoms, that they're still experiencing some body distress, and that for some folks, challenging and reframing unhelpful or stuck points was not leading to as big changes in their overall experience. So for all of those reasons, we really wanted to do our own research. And so what we did is we created a 4-session somatic group that was not based on one particular somatic approach, but rather sort of an integrative approach to bringing in different ideas that are, sort of targets in somatic therapy. We thought that it was important to offer this before they engage in cognitive processing treatment or therapy. So it happens in the 4 days leading up to their when they start CBT in the program. And in order to be able to compare the folks who do get this group to those who didn't, we do have a randomized control recruitment where we have a rolling admission at Gateway. So we will have 3 cohorts, or we have had sort of in the row of 3 cohorts who do get the somatic group, and then the next 3 admissions don't get that programming, and they get alternative programming that doesn't focus on body. We did modify some of the data collection that we had originally been doing. So we had been using the PHQ-9, the GAD or the GAD-7, and the PCL for measuring certain types of mental health symptoms. And so we just expanded the PHQ-SAD. So that is measuring, it sort of brings together items that measure depression items, anxiety items, and somatic symptoms. So we're able to measure them all together. So it was only a very minor addition, I think, of 14 questions compared to what we had already been measuring. And really what we're hoping to do is, again, to compare the clinical outcomes between folks who do receive the somatic therapy compared to the alternative programming. So everyone will still get CPT. It's just whether or not they get this addition of the somatic group before the CPT or not. So we will look at, so everyone still, whether they get somatic group or not, gets the PHQ SADs. So everyone will still be providing responses on somatic symptoms, in addition to depression, anxiety, and the PCL, which is the traumatic or PTSD related questions. And then we're going to look at, are there any differences between these 2 groups, again, on clinical measures, but perhaps also on their engagement in programming and any other sort of clinical outcomes. So just to give you a little bit of a sense of what our somatic group includes. So I said it's a 4-session program, and we've broken it up into sort of these categories. So under body understanding, it's really a psychoeducation group. So it's the initial information sharing and knowledge, much like what I did with you today. So in that group, we talk about neuroception, we talk about procedural learning and the orienting bias, and we talk about how trauma may have impacted them sort of in these ways, so that they really start to understand that, ooh, there's these other things that perhaps haven't been targets in traditional trauma treatments that have been impacted in a negative way, and to build their awareness of what those things might be. In the second session, it really is focused on body awareness. And I mean, I think this is important in a somatic group, or alternatively, it's really, I find that a lot of folks are quite unable to describe how their body feels. So a bit of a story is I do a lot of training for new police recruits. And just last week, I was asking them to tell me, what does stress feel like in their body? And every time someone answered, they would say things like, become more angry, or I'm irritable, or the ways that they were describing the impact on their body was not at all the impact on their body. And so I kept saying, no, but what does your body feel like? Right. So whether you've experienced trauma or not, body awareness is actually a skill that many people struggle with in general, and can be particularly impacted through trauma. So, for example, if someone has gone through a trauma that did impact their body directly, whether it's through an injury or something like a sexual trauma, that they might have disconnected themselves from their body, that actually focusing on their body or having awareness might be an internal trigger. I have a woman I work with who is a firefighter who, just internal signals are actually her trauma triggers. So feeling nauseous or feeling dizzy actually bring on her trauma response, right? So if that's the case for folks, they might disconnect from their body, so they try not to think about it. Whereas sometimes we see the opposite, where people again are over focused on their body, where they feel really agitated, hyper aroused, and they really can't think about anything else except their body. But again, even in those cases, people sometimes have a hard time describing what it is that they are experiencing. So part of this education is on helping them to develop awareness, not in sort of a few different ways. So one, which many of us are aware of, is exteroception. So that's, what are our five senses? So what do I taste? What do I smell? What do I hear? And that's something that people are pretty good at. But the interoceptive abilities is, what do you actually feel on the inside of your body? Like I said, I find most people, trauma or no trauma history, have a difficult time with this. So it's things like pain. What does it actually feel like? Pressure. Being able to describe your internal experience is a skill, and certainly one that most people don't have. So that is what the second session is focused on. Our third session is kind of building on that. Sort of, now that we are aware of those, can we build our capacity or our skill around controlling what our body feels like? So this is introducing that idea of the window of tolerance, and that how do we move through that window in a way closer to hyperarousal or down at hypoarousal, and what do those feel like? How do we know we're in those places? And the idea with somatic work is to build that window of tolerance, that in fact we can reach quite high in that window, and that if we need to, if we feel like we're at our very edge, what kind of skills or strategies can we use to bring that back down? And so it's helping clients through something called pendulation to experience an increase that not fully hyper aroused, but an increase in the activation of our physiological experience, and then helping them through skills and strategies to kind of bring that back down. And if they are really low in that hypo experience, what are skills and strategies that they can use to bring themselves back up? And so, because if someone were to use more somatic approaches in doing therapy more often, then it's thinking about, how do I manage the therapy session so that the client does pendulate between sort of activation and then learning to bring it back down, and then learning how to bring it back up in a way that then is tolerable. They don't become overwhelmed, and they're able to stick with their experience. And again, you can see how that might be then useful, and why we've introduced this group before they engage in cognitive processing therapy, because again, identifying and labeling and naming some of those stuck points or unhelpful thinking might increase someone's activation, or maybe it pushes them down so that they become hypoaroused, right? They create some distance and avoidance. And so having the capacity to understand what's happening to their body builds the awareness of, oh, this is happening. I am becoming higher in my window of tolerance or dropping below a baseline, that awareness piece, and then having the skills to be able to manage it and control it, and perhaps have a more wave of physiological activation would be helpful to allow them to even participate in a type of therapy like CPT, and to not either avoid or become overwhelmed during that experience. And then our last group of what we created was around body acceptance. And again, this is kind of bringing everything together and looking at how can we go back to viewing or to even start viewing our body as a source of wisdom. That, like I've mentioned, that some people through their traumatic experience might push away their body because they feel disconnected from it, they are triggered by it, they don't want to think about it, it's uncomfortable, or the opposite, where they are hyper aroused and it feels uncomfortable and it feels out of control, and they can't trust it because they think everything is threatening. And so it's going back to how can we again pull our understanding, our awareness, and our control together to land at a place where we can be grateful for the signals or signs that our body gives us, use it as a source of wisdom, and return to being able to trust ourselves as being, perceivers and receivers of information from our environment. So then, like I said, so we have this group. We just started the somatic, or introducing this group, I believe, about, I think maybe in October of this year. And so I can't recall off the top of my head how many cohorts we've had participate in this group, but certainly we'll be looking at our data soon to be able to look at. So I don't have results from our research study yet, but we likely will have them soon. So definitely looking forward to that. Okay, so I'm going to stop sharing my screen and hopefully be able to connect with you if you have any questions at this time.
Thank you so much for that presentation, Dr. Martin. I found it really informative. I'm gonna invite people who have questions to put it into the Q&A box, and then I will read the questions out to you, Dr. Martin, and we can have a discussion. I know a few people have been asking about whether we will be sending the presentation out. So yes, I just want to assure everyone that in the coming week, we'll be sending an email to everyone who's attended that will have a copy of the presentation, a link to the recording of the presentation, so you have context to go along with the slides, as well as an attendance certificate that you can submit to your association for continuing education credits. So I see a few questions coming in, and just as a reminder, feel free to type your questions into the Q&A box. So the first question is, you had described the orientation response before, and someone just wanted to understand better how to differentiate between a normal startle response versus a startle response that is a symptom of trauma.
So, I mean, I think it is quite possible that if we have, something that happens in our environment, that we could have a startle reflex rather than an orienting reflex, right? So I think that would depend on what exactly the stimuli was, right? So let's say, like I said, I'm in an office right now. I'm not sure, my background is blurred, but there's a door back there. And if someone were to gently open the door, again, my response might be an orienting reflex. But if someone were to like slam open the door, I might actually have a startle reflex because the nature of that stimuli. And I don't think it necessarily means that so it certainly doesn't mean that I have trauma in my history to have a startle reflex, right? But it potentially could look the same. It's just that for folks who have a history of trauma, that they are more likely to have a startle reflex when someone is just gently opening the door, or the stimuli that's coming into their environment isn't perhaps threatening. So I don't necessarily think that there's a difference between the startle reflex per se, but it's when it's happening, how often it's happening, and less so maybe about the startle reflex itself, but our ability to regulate after. So again, if, let's say I said someone purged into my office right now, I might have a startle reflex, but my system, my nervous system would likely be able to regulate it more quickly. My brain knows it's not threatening at that point. But if my threat detection system is a bit more taxed, if it's a little bit more sensitive because of the trauma that I have experienced, then perhaps my ability to regulate after would be impaired.
Thank you. We have a few questions about strategies taught during the body control stage. Is that something you can dive into a little deeper? Just
Sure.
examples on how to do body control.
Yes. So again, there are lots of different strategies, so I won't be able to go through all of them, but I could talk about one of them that I think could be helpful, and one is called resourcing. Um, and it's a little, so resourcing is being able to connect with either an internal experience or an external experience and focusing on how does that experience um, feel in your body? How does it influence how your body feels? And can you use one of those types of resources to induce a body sensation? So I'll give you a personal example. So about 6 years ago, I don't know if you can see it, but I got this little tiny tattoo on my wrist. It has to do with suicide awareness. So even though it's really, really tiny, it hurt. So it hurt. It took about, I don't know, 15 minutes to do. And while the lady was doing it, what I did is I closed my eyes and I pictured my daughter's face. I um I imagined us sort of like at nighttime when she was laying beside me, and I pictured her face because we do this each night to kind of put her to bed. And so the resourcing part and why this is a somatic strategy versus compared to other approaches is what I tried to then think about is if this was really happening, if I was looking at my daughter, if we were just laying in bed instead of someone scratching my arm up, how would that make me feel? Right. So I would feel warm. I would feel my tension would relax. My body would feel calm. I might, again, that warmth, that feeling of affinity, like I want to connect with her. And that impact on my body is like sort of like a sighing, a relaxing, that I'm safe, that I'm feeling good. So it's kind of extending perhaps just distraction or using imagery, but actually trying to use that experience to induce a body sensation because the tattoo was making me feel uptight and pain and comfortable. And so instead I used a resourcing of the imagery to influence how my body was feeling. So resourcing is taking those either internal or external experiences and using it to create and identify with a sensation in your body to influence how your body is feeling, which then impacts how I was doing in the moment. So hopefully that's helpful as one experience or one example.
Okay. Someone had a question when you were talking about the responses and procedural learning, and just wanted to know how that might fit with classical conditioning.
Yeah, I mean, essentially that's essentially what it is, right? So there's some conditioning that happens, right? And it's just that um uh that it's a learned body experience, right? So classical conditioning, right, is you pair two seemingly unrelated events together, which is a little bit different um, than procedural learning, where your body's learning, I don't know, that a physical or active experience in the moment. So it is very similar, and in sort of that concept of it's not at a conscious level that the learning is happening, but rather something that happens more automatically because of that paired simulate.
When you were talking about the research that's going on at the Gateway Centre in Peterborough, Ontario, on my academic brain is fascinated by that, and I know you said the results will be coming at some point. I cannot wait for that. Someone just had a question about whether there are plans underway to share that model with other organizations and anything further you can elaborate on the study.
Sure. I mean, like I said, we haven't looked at the data yet, but we're hoping to check to see our numbers and see whether or not we can kind of take a peek, right? You're having to be a little bit patient with making sure we have a robust number of participants. But certainly our goal really is to write up that to, look at journal publications, to present at conferences, and to be able to look at, the impact. And while I would love to say that, yes, we'd like to roll this out across EHN, I do value evidence-informed work. And so my thought was that we would wait to see what our results look like before we did that. But certainly if we saw a meaningful change or impact because of the addition of that programming, my hope is that, that it would be adopted by the other sites. And certainly right here, like today, like I said, I'm at ACT, and we in Nova Scotia, and so we have been talking about including somatic work. And I think individually they are being integrative in some of the one-to-one therapies that they're doing. But my preference would be to wait to see what our results are.
Yeah, I mean, I know at EHN Canada, everyone does really strongly believe in evidence-based practices, and to be in a position where we are doing research that can contribute to a body of knowledge and fill some of those lacunae is also fantastic. Just on that line, people who might want additional training on somatic work as therapists, so if there are psychotherapists or social workers or clinical counselors who might want to get additional training, whether from an institute or someone or maybe a book, do you have any recommendations on where they might be able to turn?
Sure. So I do think that at the beginning, it's really helpful to read up and figure out, I do want to sort of acknowledge that today I've been talking about somatic therapy as if it's one thing, but it really is not one thing. There are many different approaches that, are bottom up, or that have the body as the target. And so I would encourage folks to kind of start reading and find maybe one of those that feels more natural, that you connect with. And I did mention at the beginning some books that when I was on this journey of learning more about somatic work, I found extremely interesting. So The Waking the Tiger by Peter Levine, that one is so interesting. And if you haven't read it, please just go. And even if you never do somatic therapy, it's so interesting. And, he talks about why animals sort of in nature don't have PTSD and why humans have PTSD, and what that difference is, and then the implications then for treatment. Certainly the sort, I think, really famous book, The Body Keeps the Score by Bessel van der Kolk. That one is very informative. There's another one called When the Body Says No, that I think is excellent. Now, again, I can't list all the books, but those are three that I would say are really, really good places to start. And then depending on the type of somatic approach that you want to take. So somatic experiencing seems to have the most, in my sort of view, the most robust training platform or approach, that they have a very specific sort of phased approach to certification. It can be a little bit pricey, but certainly there are options online to do those trainings, and you can do them asynchronous or yes, in sort of in person or virtual. But I would say they have the most robust training available.
Thanks for that. I appreciate the books you mentioned. I know what my audiobook download is going to be next. For those of you who missed the titles of the book, don't worry. You will be receiving a link with a recording of the session. You can just come back to the section if you just want to get make sure you get the book title and author correct. Someone had, when you were talking earlier about your work with perhaps the police and finding that many of them found it difficult to maybe articulate how they were feeling in their bodies, someone brought up a point about, do you think that might be related to what the person might be used to vocationally or otherwise? For example, someone like a performer or a dancer might be, or a gymnast might be more in tune with their body and might have an easier time describing those sensations and what they might be feeling. Do you think there's anything in that?
Yeah, absolutely. I mean, I think in general, the ability to have awareness of how our body's feeling is not something we really ever learn. So in general, I think most people lack the opportunity to learn about their bodies. Now, certainly there are those folks who do end up doing hobbies or sports or activities that do have opportunities to increase your awareness. So And personally, I've experienced this. So I was a ballet dancer for most of my childhood and adolescence. And so very, everything we did was in front of a mirror. And it's a very sort of internal experience. I didn't do a lot of partner work. All of my ballet experience was sort of just me. Um, and so I have found that that has really helped me, because you're constantly looking at a mirror. I mean, it is external, but you're adjusting yourself. You're making very tiny, minor movements in your body, and having a sense of where your body is in space is really important when you're doing pirouettes. Um, or other movements. And so it is a hyper awareness in some ways of how you're holding your posture, how your body is, those again, adjustments that you have to make. And certainly I imagine that's the case for other kinds of dance or gymnastics, even some sports. And so yeah, I totally agree with that sentiment that, depending on one's other hobbies or extracurricular activities, that would influence their capacity to have that skill.
Yeah. Yeah. Just going off that, do you think there would be, or could you comment on the place for more expressive therapies like dance therapy and more of those sort of approaches, and what role they might play in trauma treatment, and whether they would fit in or maybe enable or make easier somatic work down the line?
So I'm happy to comment. I will preface that this isn't that kind of research isn't my area of specialty, but certainly there is a growing literature on things like yoga, and its impact on trauma symptoms. I do think that moving your body, and having that more internally faced awareness would be helpful, and in line with some of the somatic teachings. I know that for myself, so I do yoga every week, and I do hot yoga because I joke that then you can cry and nobody knows you're crying, because you're just sweating. And I do find it extremely therapeutic process. I'm not sure what I would isolate as the mechanism of that therapeutic experience. Right, there is focusing on your breath, which is part of somatic. Right, it helps us connect with our nervous system in a way that we're not always conscious of. There's mindfulness teachings every week when I go to yoga. There's something that I feel like I'm stealing from my yoga teacher to bring back to my therapeutic sessions. But there is that, again, focus on the body. There's the breathing. There's mindfulness. And so whether it's yoga or dance or something else sort of similar, I do think that they all include aspects that are certainly discussed in somatic approaches.
We have a question where you mentioned earlier in the talk that the somatic work won't necessarily replace CPT, but for example, in the programming at Gateway, it's done in addition to CPT, which is cognitive processing therapy. Someone just wanted to know if you could comment on how somatic work and cognitive processing therapy might complement one another.
Sure. So, I mean, I sort of think of any type of mental disorder or mental health challenge as impacting kind of in that model that cognitive behavioral therapy initially taught us, right? So that there's sort of thoughts, emotions, physiological reactions, and behavior, right? So we have these four things that are impacted by, or sometimes can be impaired by our lack of mental health or a mental disorder. And so I do think that the model is that adjusting any one of those four things is going to influence all of the other things, right? So again, the theory in cognitive processing therapy is that if we change our thoughts, that changes our emotional response, which changes how our body feels, which then influences our behavior. And so with somatic work, it's focusing on the physiological response and some of the behavior, which then if those change, the theory is that that will change our emotional response and our thoughts as well. So I do think it's kind of just finding different pathways into the same thing, right? So out of these four things, if we attack it from here and if we attack it from here, the hope is that we are actually more effective. And so I think they complement in that we're just looking at different kind of like doors into the opportunity for change. And whether or not just having them all together leads to more efficient or effective response is sort of one way to look at it. But it could also be that sometimes people, like we think about a client-centered care approach, meaning that some people might gravitate more to those bottom up, like so they might feel like addressing the body is more effective, and so actually leading with a more somatic approach might be more helpful just because the client feels like they connect with that more. So I do think they complement in each other, that they're just different doors to the same thing, but that it could also be an opportunity to have more personalized approach to trauma treatment for different folks.
Yeah, and a personalized approach is always important because people's individual experiences and manifestation of trauma, you can't have a one-size-fits-all approach. There's the evidence-based techniques that can be followed and should be followed, but of course tailored to the individual needs. Just on the line about complementing therapies and other approaches, for those who might not be too familiar, how would somatic therapy and EMDR fit together?
So I am not trained in EMDR, but EMDR is an example of accessing the somatic responses of trauma. It's recognizing that it is considered a closer to a bottom-up approach, and so I do think that they are more alike than cognitive processing therapy, let's say in somatic approach, but I can't comment specifically on EMDR.
I just want to really thank you and appreciate that you've left so much time for Q&A after the presentation. I know people have had a lot of good questions, and I think this has been really informative and really helpful. And also people have shared some of their comments just in terms of, how, the talk describing how trauma might sit within the body, and that might relate to other cultures and cultural manifestations of mental health concerns, where someone, feeling blue might manifest, physically, for example. We don't have too much time left, but I think someone just wanted to have some advice on what they might look for if they want to search for a trauma-informed therapist for themselves, or someone who needs that. Do you have any advice for someone who's doing a search?
I mean, from my experience, whether it's a psychotherapist or another healthcare provider, they do a pretty good job in their biographies, or that section of their website where they are indicating that they're interested in doing trauma work. I would look for someone who has specialized education or workshops in some way, because remarkably, I will admit that during my PhD, I did not take anything on trauma treatment, right? So it is quite a general approach to our training, and so everything that I have learned has been in addition to. So I would work. Like I said, I do think that people are really upfront in their bios to say whether or not they want to work with trauma. But I would look for someone who has training in trauma work, just because I would, like anything, whether it's my mental health or physical health, I would like to work with someone who, again, has dedicated their experience in that way. So that would be my suggestion.
Well, thank you so much for sharing your expertise with us, and thank you to everyone who has attended. A reminder to opt into our webinar opt-in form. We've linked it in the chat so that you can stay updated on webinars like this. And we look forward to the outcomes of the research, Dr. Martin.
Thank you so much for having me. And thank you to everyone who joined.
Thank you.